Hi, everyone. I am going to be presenting here what I consider to be a mini lecture, kind of an introductory lecture to the idea of diagnosing mental disorder. And initially, I was going to cover this during our live Zoom meeting during the first class, the synchronous meeting. And then I thought about it and decided it might be better to do this the way that I'm going to do most of the other lectures over the course of the semester, so that you can see how I'm going to be handling things. I am planning on doing this for everybody, making this available, irregardless of status of face-to-face classes or anything, because this way everybody has access to the same exact presentations at their convenience. Okay, so there are going to be a couple of differences as we go through this. Typically, all my notes will come up line by line, and there are a couple clusters in this particular lecture outline for purposes of expediency, kind of, if you will. But I want you to recognize that on D2L, you have this exact complete outline, as well as this outline in a partial form, so that you can print that out or whatever and fill in any of the missing parts. Okay, so I'm going to be bringing this outline up for you. I sure hope. And it will be presented pretty much as a slideshow like this, okay? And so the diagnosis of mental disorders, and this is really dealing with the idea of what is and what is not a disease or disorder. Again, I'm going to be using disease and disorder kind of interchangeably at this point. And there is the example of the Pied Piper of depression, or Prozac. I'm going to change that in the notes ultimately, but so it can either be the Pied Piper, Prozac, or depression. And it was a Dr. James Goodwin who back in the 90s would see patients. And many of these patients who came to see him were given the diagnosis of mild to moderate depression, although they really didn't have any idea that they were depressed when they came in to see the doctor. And most of these individuals were placed on Prozac. He did, in all fairness, also suggest cognitive behavioral therapy along with that. This article that is associated with the link that I posted here for you is a little review of this, and it indicates that it was thought that James Goodwin actually suffered from bipolar 2. You might find it interesting. It's short and will kind of introduce you to some of the thoughts back then. Interestingly, in every case, excluding the bipolar patients, so this is unipolar depression, within 3 weeks or so, these patients who were treated with Prozac reported functioning better, feeling more healthy, feeling more self-actualized, especially if they were closely following the treatment recommendations given to them by Dr. Goodwin. This should sound a little suspicious to you, because most of you probably know that most antidepressants take 6 weeks or more to fully exhibit their treatment efficacy, to really help alleviate a lot of the symptoms that were presented. Now, it doesn't mean there can't be any relief from depressive symptoms at 2 and 3 weeks. It just generally takes longer than that to completely realize the effects of that medication. Now, you're like, this is awesome, great. Now we have a bunch of patients who really, they went to the doctor because something wasn't right. And then they were given this diagnosis, and then they had a treatment plan, and they were feeling better. They were more productive. However, especially at this point in time, they became the victims of a stigma of depressive illness. They were judged by laypersons in a negative way if it came to getting insurance coverage for something, if they were applying for jobs. Even friends and family would sometimes stigmatize them because of this label, albeit a diagnosis, of depression. So here is a problem that really was profound at the beginning of this understanding of treating depression and antidepressants and so on and so forth, that very normal acting and appearing people responded to treatment for depression. And once they are treated appropriately, they're like, yeah, I feel better now. I was pretending a lot. I really didn't feel right. I was really sad. I couldn't focus. I had no motivation. I put on a good face. But now I'm treated for this depression, and wow, it's so much better. That should be a positive thing, and yet they were treated poorly in many, many cases by their peers who were not treated for anything. And bear in mind that some of these untreated peers may have actually benefited from some kind of medication. Now, I want to stop here and make sure this is not a plug for, okay, if you feel a little depressed, go on and get some medication. Just go get put on antidepressants. We will be talking extensively about the dangers therein later on. What I'm trying to do right now is point out the fact that if somebody is being treated for a disorder, even if it seems mild, and they feel better, it's really, it's unfair to think that suddenly they're stigmatized. This link takes you to the CDC fairly recent reports of the incidence of mental illnesses, especially in this country. I'm going to give you some stats here. An estimated 57.7 million Americans meet the criteria for a diagnosable mental disorder in any given year. That means that 26.2% of Americans ages 18 and over, which is equivalent to around 1 in every 4 adults, is actually diagnosed. And about 1 in 17 are actually suffering from what would be considered a serious mental illness. So we're not talking about a mild to moderate depression or maybe limited anxiety issues. We're talking about the completely debilitating depression and or anxiety, not leaving the house. We'll talk about things like that, not being able to be anywhere. Some of you know the term for that, hopefully. Talk about that later when we get to the different disorders. Things like schizophrenia, especially uncontrolled schizophrenia. And mental disorders are the leading cause of disability in the United States and Canada for ages 15 to 44. That's pretty serious. And more than 60% of individuals with a serious mental illness may not even be receiving treatment. It's been found that younger, seriously mentally ill individuals, and we're looking at the 18 to 34 age bracket, were actually more heavily represented in the untreated category. Also, the rurally mentally ill are actually more likely to get treatment than their urban counterparts. In the study that was cited in the literature from which I pulled a lot of this statistical information, these studies didn't include homeless or institutionalized persons, which is important because initially I was thinking, well, they're probably not taking into account homeless. And so that would skew the actual numbers. However, these homeless were not even included. Here comes another situation that we need to think about, and this has been very heatedly contested or debated amongst all different kinds of disciplines and professions and professionals. When should insurance cover a mental disorder? Now, this is where the diagnosis and the concept of mental disorder is extremely important. For example, we can go completely out of control with our diagnoses. In some cases, a child who didn't like doing his math homework and really made a huge fuss and became very temperamental was actually diagnosed as having a mental illness, developmental arithmetic disorder, which does not even exist in the DSM. Excuse me. A child who argues with their parents may be diagnosed with oppositional defiant disorder, which we talk about in neurobiology of childhood mental disorders. I'm going to need water. People who are critical of legislation that proposes to end this discrimination may find themselves diagnosed. Okay, sorry about that. I literally had to go get a drink of water, and I'm leaving this all in because I want these lectures to be as spontaneous and classroom-like as possible. And those of you who've had me before know that sometimes I say goofy things and whatever during class. So some of that might happen here. So forgive me for that. Anyway, I was talking about money and madness, and number 3, this has not happened, but this was an example I found in some material from which I drew this lecture as being diagnosed with denial and non-compliance with treatment disorder. The idea here is that we need to be very careful about calling something a disorder. And we need to understand what a disorder truly is as perceived by our society, and that's part of it here, before we can even talk about whether insurance should cover it. So, legislation would require that caps on coverage be the same for mental disorders as they would for others, for medical illnesses. And I have my own very strong personal opinion about this, that your brain is part of your body, and that if you have damage to your brain from anything, that is a physical thing. So we'll be opening that up for a little discussion at some point. Anyway, some critics contend that the psychiatric, quote, mental illness or disorder, unquote, as described in the DSM-4 revised, which is now the DSM-5, is a subjective diagnosis that actually lies in the eye of the beholder rather than in proved medical science. Herein lies the problem. So, is it subjective or is it objective? So, important questions that we really need to look at. And you may be like, oh, this is like, oh, really? Does mental illness exist? The next lecture is completely dedicated to the concept of mental disorder or mental illness. And in the opinion of some individuals or societies, this is not a hard and fast fact, the idea of what mental illness actually is. So the next question, is there an objective way to classify mental illness? Can we do that so that perhaps we can get coverage? And when are people with mental illnesses responsible for symptomatic behavior? This is huge. I am going to touch on a sociopath, psychopathology, and this is an area that that causes a lot of confusion and disagreement in terms of responsibility of the individual. So the important implications include money, insurance costs, criminals, should they be treated for mental illness, and I have any more. I want you to think about other implications. Take a few minutes and just, if you have a really good idea of one, or if you have a question, let's say, I wonder if my idea would be an important implication, you can shoot that to me in an email or post it on D2L under any general discussion board that I put up. I'm not going to require you to do that, so please don't worry. I just want your input if you have something that you really would like to talk about. And this last, but certainly not least, is an article, and yes, it's Wikipedia, but I actually looked through this and it's pretty, it's pretty accurate. And I wanted to bring this up because I actually saw this, the author of this particular article, Irving Kirsch, speak at one of the conferences I attended a few years ago. And he is basically arguing against the use of antidepressants. He is saying that the chemical imbalance theory of depression is wrong, and that antidepressants have little or no effect on depression, but because of their common serious side effects, they actually act as powerful active placebos. And I know in the talk at which I attended of his, he was really saying that the only things that were getting published, the only papers, results that were getting published, were those that actually supported the idea that antidepressants are effective in the treatment of depression and associated disorders. And he presented a lot of data from smaller, more private studies, groups that had smaller studies. And I really encourage you to read through this. I think I'm probably even more affected by this because I did see this individual speak. And I'm just going to bring you here to this last paragraph about Kirsch addresses the conclusions of a 2004 study that if one antidepressant doesn't work on a patient, another should be tried in its place, and then another, and until hopefully one will be found to be effective. Okay. And it goes on to cite how many patients were helped by the first antidepressant, and so on. And last here, Kirsch cites a 1957 study in which volunteers are given a drug that induces nausea and one to treat nausea. If the anti-nausea drug failed to prevent nausea, they were given another. If that failed, another was tried, and so on. All volunteers experienced complete relief from nausea by the sixth treatment. Yet every single treatment was a placebo. So Kirsch's conclusion was that the results of the 2004 antidepressant study are due to the placebo effect, most likely. And he really argues against the chemical imbalance theory of depression, because he said so much of that is based on whether some of these antidepressants work or not. So I included this whole section here. I do think this is pretty important for you to be aware of. So often we only get one side of the story, and it's important to see the other side of the story. And there are some out there that never really get recognized. I'm going to move myself out of the way. And in 2012, CBS actually featured Kirsch in a 60 Minutes episode. And so I think this is an important concept, important article and body of literature for you to kind of pay attention to. So, having said that, I'm going to stop the share now and get back to you in full form. So this is kind of just a sample of how material will be presented. You'll see that I am actually using the outlines that I'm posting for you, and they're going to be posted ahead of time. And I'm going to try to do these recordings ahead of their scheduled topic date. That way, if you want to work ahead a little bit, you can. You can always catch up if you get behind a little bit. And this is one aspect of the course that I want you to know will remain constant. I just think it's super important right now to have certain things that you can count on as being constant. And this is one of them. So I really hope this has been beneficial for you. I hope that this very first mini lecture has at least prompted some thought about things that we take for granted in today's medical world. I also want to tell you, you do not need to memorize specific statistics for my course. And that is for more than one reason. And some of you know this because you've had me before. I give them so you get a sense of how prevalent something truly is, because that should be impactful. That should help you understand why it's so important for us to actually talk about these things and learn as much as we can and be educated. However, you can look in 3 different sources and find 3 different statistics. Though they should be in the same ballpark, but they'll be different. Secondly, I don't want you spending time memorizing statistics that may or may not change within the next week. I want you to spend more time understanding the principles that underlie what we're going to do, and you're going to have enough memorization with in regard to the neuroanatomy, knowing the structures of the brain, learning about some of the things like the resting membrane potential and the action potential. Please, please do not spend time worrying about specific statistics. I hope that gives you a little encouragement that you can do this, and I am looking forward to talking with you again in whatever form we actually do. And